First of all, I would like to thank the editors of Clinical Gastroenterology and Hepatology for giving us the opportunity to present our work through this video. I would also like to thank my co-authors, especially first author Elvström, who has been working hard on this paper. I want to present some data about a recent paper about celiac disease and gastrointestinal cancer in Swedish patients undergoing biopsy. This paper was based on some 28 to 29,000 patients with celiac disease and a large number of patients with other mucosal appearance as well, inflammation, MARSH 1 to 2, as well as a third group consisting of patients with a normal mucosa but with a positive celiac disease serology at time of biopsy. We collected these data from all Swedish pathology departments in Sweden. They were 28 in number, and then we linked these biopsy data to the nationwide cancer register, which has been operating since 1958. We then calculated the follow-up from first biopsy until cancer, or when no cancer occurred, until emigration, death, or end of follow-up in time. Through this, we were able to estimate hazard ratios through Cox regression, a survival analysis, hazard ratios for cancer in the GI tract. What we then find is a very interesting pattern. We find a high increased risk of GI cancer in the first year of follow-up, independent of the mucosal appearance of the small intestinal biopsy. In celiac disease, we find an increased risk. In inflammation, we find an increased risk. And in patients with normal mucosa but positive celiac disease serology at time of biopsy, we find a high increased risk between 5 to 10 times increased risk of GI cancer in the first year of follow-up. After that, the excess risk disappears. There is no increased risk of GI cancer beyond the first year. When we looked at different strata, like men, women, like different age strata, like different calendar period strata, we see the same pattern. We see an increased risk in the first year of follow-up after celiac disease diagnosis or biopsy with a different mucosal appearance and GI cancer. But after the first year of follow-up, we see no such increased risk. Among the strengths of our paper is the large number of patients. Evidently, we were able to make stratified analysis. We were also able to calculate confidence intervals which were rather narrow. And that means I'm quite certain about the conclusions. However, we also have some limitations. For instance, we were unable to consider smoking and body mass index, since these data are not recorded in the nationwide registers of Sweden, except for the medical birth register. In conclusion, we see an association between having a biopsy independent of its appearance and GI cancer in the first year of follow-up, and after that we see no increased risk of GI cancer. I believe personally that the increased risk in the first year is due to confounding by indication. And with that I mean that a patient having a GI cancer may have symptoms from his or her GI cancer leading up to an investigation of the upper GI tract. During this investigation, biopsies are taken from the small intestine, and some patients would have celiac disease, others would have inflammation, even others will have a normal mucosa. Even only after that is the GI cancer identified, and it seems that celiac disease precedes the GI cancer. I actually think that they're very tight together, and that it may be symptoms from the GI tract leading up to the celiac disease diagnosis. Thank you for listening.